I'm Dr. Jesse Botker from Mankato Orthopaedic Fracture Clinic.
And I'm Dr. Scott Allen from the Mankato Orthopaedic and Fracture Clinic.
We're here today to discuss anterior toe hip arthroplasty. What are the indications? Do you really need it? Why is this better or maybe equal to a posterior hip?
A direct anterior hip is the approach or the way that we get into the hip joint. There's two very popular ways of doing a hip replacement in the United States. The first is from the back, where an incision goes closer to your hip or on the backside of you. The anterior is an incision on the front of your hip.
Now, most times with the back approach, people talk about cutting through the muscle. It's really different. I mean, we actually split the gluteus maximus muscle. There are a few tendons that we do take down the back. We do repair them at the end to lessen your chance of dislocation.
An anterior hip is a true muscle sparing approach where we work between the muscles and move them out of the way to get into the hip joint to do the surgery in a theoretically less traumatic fashion.
What we found with the anterior approach to hip arthroplasty, and all the studies would back this up, is over the first 6 to 8 weeks, your recovery comes along a little bit smoother. You're able to walk farther distances right away after surgery. You have a little bit less pain. There's less overall restrictions compared to a posterior total hip arthroplasty.
Long term, the outcomes from an anterior and a posterior approach are about the same. The studies would not suggest that one is truly better than the other. The difference tends to be early on.
One of the only differences, that slight difference in variation in the studies, is there's a little bit less of a dislocation risk posterior to anterior. However, you can still experience a dislocation coming through an anterior approach.
Most anterior hip surgeons, and myself and Jesse included, would not put specific restrictions on how you move your hip after an anterior approach, whereas most of us would limit some of your motion from a traditional posterior approach.
The posterior approach restrictions are usually in place approximately 2 to 3 months. That's all surgeon dependent.
Not everyone is a good candidate for a direct anterior approach. One of the biggest limitations is if you have bigger legs or a bigger stomach, that can make approach or getting into the hip joint itself more challenging from a direct anterior.
We typically tend to favor patients that are a little bit lower BMI overall. Certainly that can vary as far as where your extra weight may be distributed. So not every patient that is slightly overweight is not a candidate. And vice versa, some patients that may be more muscular sometimes can be more difficult as well.
The anterior approach is not without problems in and of itself. The incision goes on the front, and the top of the incision tends to sit right at your belt line. So sometimes the incision can be a little bit slower to heal, especially at the very top part. There's also a nerve that goes across the front of the hip, and sometimes you can have some numbness or tingling on the side of your hip after this incision.
I'd say that's the biggest complaint I see of patients afterwards, is that you do have that area of numbness, typically around the incision, but that numbness can extend all the way down to the knee at some point with certain patients.
Yeah, I would agree. Overwhelmingly, I would say my experience with the direct anterior is that at the 2-week visit, most patients come in and say they feel pretty well. Most are taking only Tylenol and ibuprofen, and the overwhelming majority are walking without a cane or crutches or any sort of walker.
Yeah, I definitely would say that's the biggest thing I've seen difference. I certainly did the posterior approach for many years and still do it. I think it's still a really good approach. And just because you have that approach does not mean that you're going to have any long-term deficits or outcomes overall. As we said earlier, this is primarily the very early part of healing that we're tending to see that patients are recovering a little bit quicker from.
I'd say one of my biggest benefits of doing the direct anterior is real-time feedback during the surgery. The way that we position you during surgery allows us to use an x-ray machine to get real-time immediate feedback in where the implants are positioned, and we can make adjustments to it if we don't like how those components are placed.
I would completely agree. I think that the x-ray during the surgery is very helpful. What I tend to do as well prior to surgery is we'll take a templated x-ray of your hip. We're able to position the parts on that digital x-ray and kind of see in the ballpark of where we're going to be at. We're able to kind of match up your leg lengths, your offset of how far wide or narrow that your hip is. We want to really just restore your native anatomy as much as we can. Obviously, there's going to be some wear of the hip. We tend to have some joint space space narrowing, sometimes even collapse of the ball of your ball and socket joint. So sometimes patients will notice that their leg is much shorter than the other side, and so we want to try to lengthen that out at times, and that real-time x-ray feedback allows us to do that during the surgery.
I agree completely. I like to template all my direct anterior hips as well, and use that intraoperative x-ray to make sure that the components are exactly where I want them to be.
I think the key at the end of the day is that, whoever you're going to come see for your total hip arthroplasty has experience. Certainly myself, Dr. Allen, there's other doctors at the Orthopaedic and Fracture Clinic that are very experienced. We pride ourselves on our years of experience and our volume of cases. But the anterior approach is becoming something that has been becoming very popular with patients. Certainly if you're going online and reading about it, and we're very proud to offer this option to our patients through the Orthopaedic and Fracture Clinic.
Absolutely, I agree.
So we're going to go into and see an actual surgical video. We've gotten permission from one of our patients that you're going to see the whole entire video. And so certainly there can be a little bit of disclaimer here. There is a little blood. Certainly if it's something that you're queasy about watching actual surgery, you might want to just turn the video off now. But if you want to proceed and see exactly how we do this and see how we get the different x-ray shots and how you're positioned during the surgery, I think it's a very educational piece for patients. And we can talk, certainly this patient that we're doing is a 50-plus-year-old female. She has given us permission to do this, and obviously has been, quite pain and quite a bit of pain and limitations with their activities of daily living, severe, limitations and all those things, has a pretty significant limp, has been putting up this for many years. And certainly, indications for surgery, we're looking for a patient with, bone-on-bone arthritis, somebody that's, having severe limitations of activities of daily living, quality of life. That's who we're really shooting for here.
Yeah. A hip replacement really helps people restore their quality of life. It's really a life-altering surgery for them.
I'd certainly say, if you look at total recovery time, it's a pretty common question that I get. I'm sure you do as well. Yeah. End of healing, 1 year. We expect that you're going to continue to see small improvements out to a year after this particular procedure. I would say, though, that the biggest, jump in improvement is probably within the first 3 to 4 months ballpark on average.
Yep. Absolutely. The first couple of weeks are definitely the most challenging for people as they get over the surgical pain, but restoring some of that motion and strength that can really limit people for years before they get their hip replaced takes a while.
I do think it's important. Typically we have patients do physical therapy on their own at home after this particular procedure, which is very nice. However, sometimes you're going to need a little bit extra therapy. If we feel that's necessary, we will get you in for formal therapy. However, regardless of whether you do formal therapy or not, I think it's really important that you follow through on your exercises. The stronger you get, the better you're going to feel overall, and the more normal your gait pattern is going to become. I'm Dr. Botker, Orthopaedic and Fracture Clinic. We're here doing an anterior approach right total hip arthroplasty on a female patient. So we'll kind of talk you guys through the whole procedure. All right, guys, so our incision here is right in the front of the hip. So right now we have the anterior superior iliac spine, and typically the incision comes off about 1 centimeter lateral, 1 centimeter below. Very cosmetic, incision overall, pretty small. Usually, can we have a measuring stick? There we go, perfect. All right, so typically on these incisions here, this particular incision, we're measured out about 9 centimeters. Typically 9 to 10 centimeters is about the average size of this incision. So, all right, make an incision, guys. So the big thing with these anterior approach total hips is there is a skin nerve that supplies sensation to the front part of the thigh, and that skin, those nerves can get somewhat irritated during the procedure. So we're trying to just dissect through here and stay away from those if we can. That's called the lateral femoral cutaneous nerve. So we're just going to be dissecting through kind of the fat tissue here, adipose tissue just below the skin. As we come through this layer, we're going to come in, we got little bleeders here. We just kind of cauterize any little bleeders as we, little blood vessels as we go. Sometimes we're able to see little branches of that nerve as we come through. Typically we'll take those towards the front. So occasionally patients will have a little bit of numbness on the around the incision site. Probably about 50% of the cases there'll be a small area of numbness.
Some patients don't have any. So as we get down a little bit lower here, we're going to see, we're starting to get into the, do you have pickups, please? This is the muscle fascia right here. So that's the outer layer of the muscle. This muscle is called the tensor fascia lata muscle. And so we're going to go through just a little bit through that, the Mets, please. You go just through that muscle fascia here quick. All right, so we're kind of just exposing there. So now we're going to take a little clamp. We're going to grab that muscle fascia here. And we're going to kind of sweep the muscle belly away from the outer covering. So the outer covering, that fascia, we're just developing the plane. So we're going in between the muscle. We're not damaging the muscle. So that's your tensor fascia lata muscle that we are exposing right there. That's the fascia just above. And then I'm sticking my kind of bluntly dissecting with my finger here. Can you have the number 1 retractor, please? I'm going to put this first retractor in right next to the femoral, kind of side of the femoral neck. Let's have the Kelpie. And we put the second retractor in to kind of spread. So as we go through here, we're going to kind of develop this next little tissue plane. This is going to be going through the kind of the base of the fascia. The second muscle here that we're going to expose is the sartorius muscle, which is right here. So we are just kind of developing this tissue plane. Typically, as we get in here a little bit lower, or into a little bit deeper, we're going to get into just a couple little bleeders. We're just going to cauterize those bleeders. And there's a major blood supply to the hip joint called the circumflex vessels. So in a second, we're going to cauterize those circumflex vessels. And those vessels are kind of right in this region right here. So we're just going to kind of come through this next little layer here. Thank you. And coming through the base of the fascia here. And then I can see the leash of vessels is right here. So there's my leash of vessels coming right across. We're going to take our little cautery device here. And we're going to just kind of cauterize those vessels so they don't bleed. Once you put the total hip in, those vessels are not as important. You do get collateral flow from around that area. So we're going to just come right through the vessels here, kind of release those. So next layer here, as we kind of come down, we're just going to stick our retractor in just a touch deeper and expose that area. So the rectus femoris muscles are going to be the next muscle that's a little bit deeper here on the hip joint. We're going to go ahead and just kind of release the joint capsule in the front, staying just to the outside of that rectus femoris. So as I enter right into the hip joint capsule here, sometimes we'll get a little bit of fluid. Not too much fluid today. I'm just kind of going right into the hip joint here. In a second, we're going to be able to see the hip joint. So we're going to put one other retractor in here in a second. Let's go ahead and have that Alexa retractor. All right, so this retractor right here is called an Alexa retractor. This kind of just holds the soft tissue away. So typically, we come right underneath our tensor fascia lata muscle here. All right, so now this little retractor is going to find its home here, right inside, underneath this muscle. And this kind of just protects the muscle throughout the procedure. It allows visualization. There we go. All right, there we go. Now we're sitting good. Okay. As we put our retractors in here, we're going to be able to visualize a little bit better. Number 2 retractor, please. In a second, we'll have much better visualization here as we release. We're kind of releasing this soft tissue right up onto the edge of the socket. Pretty large bone spur right in the front part of the hip joint here, which is kind of holding up our visualization a little bit. So we'll expose that better here in a second. All right, so we're going to put a couple tag stitches in, kind of hold our tissue away. We're going lateral with this first one. All right, so we're going to put our first retractor right on the side of the neck of the femoral head here. And as we can see right here, we have a very large bone spur right in the front part of the hip joint here. So that's the ball joint is up above here, and the hip socket, and then we have this very large bone spur. This bone spur is kind of holding us up, so we're going to just take a runger. So we're going to make our neck cut here in a second, but we're just kind of clean things up here. Trying to get this the second retractor into position. There we go. Now we can see. There we go. Okay, so now we are exposing the femoral neck here, and we're going to be making our cut in a second. So I'm just going to release some of the tissue along the joint capsule tissue. There you go. Thank you. All right, so we kind of exposed the area. So we're going to put another tag stitch into the joint capsule in the front part of the hip here. And again, this will just kind of hold back that tissue later on as we're moving our instruments in and out of the hip joint. All right, so we're going to come in with our x-ray at this point. Let's come midline for me right there. So based off our pre-op plan, I want to make sure my neck cut is at the proper length. So right now we're a little bit long with our neck cut, so we're going to move that down slightly. Shot there. That's going to be right about right where we want it based off our preoperative plan. So go ahead and pull back out. Take number 2 retractor, please. All right, so we kind of expose this area. What we're going to do now is let's go ahead and a little bit extra rotation on the leg. And traction, yep, external rotation for me. I'll take this saw. And this saw blade here just cuts at the very tip, so it's very controlled. So as we go through, I'm feeling kind of through that second cortex. Now, once we kind of completed it, it'll kind of pop free. So now we can see that we have the neck cut here, and we have the ball up top. And what we're going to do is we're going to put this corkscrew in, which is going to capture that ball. All right, so now what we're going to do is we're going to release, there's just some joint capsule. Go ahead and come out with this one. Joint capsule that we're going to release on the back half here. Go ahead and hold that up there for me. So we'll do some releases here and release that tissue so we can pull this head out. So what we're going to do is just kind of roll this here. There's a little soft tissue attachments in the socket. So once I kind of roll this, we're just going to pull this out. Now we can see that we have the femoral head. Whoops, can I get another lap sponge, please? All right, so we can see on this that we have quite a bit of wear of that femoral head there. So there is not much cartilage remaining on that. The ball is kind of misshapen. That's typically what we see as the hip joint wears. All right, so our retractor here just kind of came out of the soft tissue or out from underneath the muscle. So we're just going to readjust this here. There we go. There we go. Much better. All right, so now we're going to have a hole into the hip socket here. Let's have a number 1 retractor, please. So our first retractor is going to go right back up over the front edge of the socket. Second retractor will go right below the back half of the socket. Exposing the socket, I'm just going to release a little bit of the capsular tissue at the base of the hip here. So that's just the inferior capsule I'm just releasing. All right, so go ahead and let down traction, please. So we pulled a little bit of traction just to kind of help pull the ball out of the socket a little bit. Now we're going to let that traction off. So right now we can see the hip socket. Now the hip socket's got a labral tissue, which is the ring of cartilage all the way around the edge of the socket. And we're going to go ahead and remove that right now. So we're removing kind of the back half of the labrum. And typically we'll see a labral tear associated with this with the arthritis. So this labrum does not serve any function at this point with the hip replacement. And then we'll also remove the tissue at the base of the hip socket. This is called the ligament teres. This tissue again doesn't serve any purpose, and we're going to be putting our titanium socket here in a second. There is a small blood vessel that typically, here you go, we'll have a little bleeder at the base of the hip socket. So we're going to go ahead and just cauterize that. All right, so now we have full exposure of the hip socket. All right, so we can go ahead and come out with those retractors. So at this point, what we're going to do is we're going to start with our circumferential reamers. These have a very sharp tip on them, and we are able to ream out the bad bone and cartilage on the socket. So my assistant here, April, is going to hold back the soft tissue so we can slide this in without causing any damage to the muscle tissue. Now we're going to come in with x-ray. So based off our preoperative plan, we're going to go ahead and take an x-ray, and we're going to make sure that the pelvis is level. And you're going to come all the way across. Yep, right there. So at this point, I'm utilizing x-ray. Can we rotate the image a little bit clockwise, right? Just a touch more. Right there, okay? So we're going to use this x-ray to kind of see how deep with my reamer I can go. So as I ream towards the inner wall of the pelvis, shot, I can see that I'm symmetric on the shot. Let's go ahead and 49 it. And I should be able to get good, I'm going to have you take that. Good bleeding bone and cartilage here. I'm just going to take a peek into the hip socket. I got to go a little bit deeper with it. There's pretty hard sclerotic bone anytime you have worn out hip joint with the arthritis. So it really, we're just kind of reaming through that hard bone and cartilage. So we incrementally ream up here. We're usually going by 2 millimeter increments on the reamer. And so we're kind of putting this all the way down to what we call the teardrop. Okay, shot. So it's just a bony anatomical landmark on the x-ray. So you make sure that we have good bleeding bone around the periphery. Now we put in a 51 millimeter reamer, and it looks like we're going to probably end up putting a 52 millimeter cup in just based off the plan. Yeah, that looks pretty good. So we have good bleeding bone on the edge of the, all around the edge of the socket. Yeah, excellent. Okay, we'll touch 52. Go ahead and open up the 52 cup. So we're reaming to a 51. I'm just going to take the 52 reamer, and I'm just going to barely touch the edge of the socket. This is just to let the cup kind of sit down a little bit more nicely as we put it in. Good. Yeah. All right, so then we'll irrigate out the hip joint here. It's a little bit of bleeding, but that's good. We got bleeding bone. We want bleeding bone for ingrowth of this component. Cute. So you can see on the back side of this cup is a porous metal coating. So the bone your bone will physically grow into this cup and integrate. There's 3 little holes here that if you want to put screws in, we could put screws in, which we're not going to today. We typically don't put screws in unless for some reason the cup doesn't sit flush. So I don't anticipate we'll need any type of screws today. And so we'll just kind of angle this in. Go ahead. We'll maneuver the cup past the soft tissue until it kind of sits down. Yep, there we go. Good. Okay. All right, come back in with x-ray, please. All right, let's take a midline picture first. Yep, go ahead. All right, so we know that we're nice and even with our pelvis on the x-ray. I can see the cup sitting up slightly. We want to put the cup in about 40 to 45 degrees of what we call abduction and about 20 to 25 degrees of version. About right there, shot. So as I like that, what I'm going to do is start to pound this cup in, shot. And we'll see the cup kind of sit right into its home. That's sitting pretty nice there. And it's sitting down right on the x-ray. So what we'll do is we'll be able to take this inserter handle off now. And we'll just kind of suction here, make sure that the cup is sitting all the way down. There's a little hole where the inserter handle goes, so I can see that we're right against the edge of the bottom of the socket. We can see on the x-ray the cup position is pretty good. We're just going to wash here a little bit more. Now this cup is made of titanium alloy, and the cup has got a locking mechanism on the back side. We can go ahead and pull it back x-ray. So on the back side of the cup here are some ridges that lock right in. And so this plastic is a vitamin E infused polyethylene, and that is what we're going to be walking on. So we're going to snap that into position here. We'll take the inserter, or the impactor. Okay, good. Once that's fully seated, the cups should absolutely flush in the locking mechanism, which we look pretty good there. So good. So now our cup is positioned. Really like that. If I feel all the way around, I don't feel any overhang on the hip socket. So we're going to go to our femur now to implant the femur side. All right, so we're going to come right around the edge of the trochanter bone here, and we're going to separate out our, once you, at this point, can you reach underneath? Yeah, there you go. All right, so we're going to kind of release our capsule tissue here. So we're going to expose the femur here, so we're just releasing some of this joint capsule from the outer part of the hip here. In a second, we'll have pretty good visualization of what we're trying to look at. So we're putting our retractor over the top of the trochanter bone here. And we still have a little bit of releases to do to really get good visualization of what I'm trying to see here. So we want to seat this component in the right spot. So this is very important part of the procedure here, that the implant sits in the proper spot. Properly size the implant, as there's an ingrow surface again on the implant that we want to grow into the inside of your femur bone. So very important that we get all the way out and position properly with this. So we have the cut end of the femur here that we have good visualization with. We have retractors in place. All right, one more time with that rongeur, please. All right. So now we're going to take what we call the box cutting osteotome. This is just going to remove a little bit of that bone from inside the femur. All right, so we can see the cut end of our cut portion of our femur here. And we can have some bleeding bone. And we're going to go ahead and just expose this a little bit further here. All right. So this is our starting reamer. There's very sharp teeth on this. And so what we're going to do is this is going to start kind of expanding the inner part of the femur bone here. Now our plan calls for a size 5. So this is what, 0? Okay. So we are going ahead and just kind of incrementally increase in size. This is a size 1, so we're going all the way up to a size 5. There you go. So we'll be able to trial off of this with the temporary implant in. All right, so we have different neck angles, so we're going to snap our neck portion on, and we're going to snap our ball on here. There we go. Good. Okay. Okay. All right, so we're going to put the hip back into place. We put it one size bigger stem in. Go ahead. And this is a nice thing about using X-ray during the whole entire procedure. We're able to really dial in your hip joint, match up leg lengths, match up offset, match up the size of the femoral stem. Go ahead and take a shot there. And now we're looking at it, and we're even closer. All right, so now we are going to implant our final stem in place. All right, so we're going to go ahead and pound the trial stem out. Now we're going to go ahead and just remove any kind of bleeding excess bone. We have great visualization of our neck cut. We don't have any concerns. That looks great. Now we're going to go ahead and implant our final stem. So here's our final stem. We can see there is a porous coating, hydroxyapatite coating around the whole entire stem. The stem will sit in nicely and kind of wedge right into place. The bone will go right onto the stem and lock it in position. And once that stem finds its home, it sits in there and it is rock solid. All right, so now what we're going to do is we're going to go ahead and give me a lap sponge, please. I'm just going to wash off. This is called the Morse taper. This is a tapered surface on this titanium component. And what we're going to do is we want to clean that up nicely. We're going to pound on the final ball. So we went up with a 3.5 millimeter increased size. This is the pink ceramic that we're going to use. So we're going to be ceramic on polyethylene plastic. And so what we'll do is we'll go ahead and pound that right on the Morse taper. And once that's seated, what we'll do is we'll take our retractors out and we're going to put the hip joint back into place. All right, we can go ahead and reduce. So the nurse is going to pull up into position. Yep, you're in. And she's going to let off traction. She's going to put the hip joint right back into place. If we look at the patient's width from side to side, the width looks good. We're going to just check our leg lengths at this point. And we should be matched up pretty nicely as far as the leg lengths go. And we're very close to what the patient's preoperative anatomy is. So at this point, we can go ahead and out with x-ray. So we have the hip joint in place. What we're going to do now is we're going to wash out the hip joint. As we can see here, we've gone between the muscles. Very minimal damage with this retractor in place to any of the muscle structures. We have really minimal to no bleeding here, so we won't have to put any type of drain in. And so we'll allow this patient, after anesthesia wears off, to be up walking on the hip later today. And we anticipate that the patient will discharge to home tomorrow.